Welcome to Raaonline. Today's topic is Endocrinology of Hyperprolactinemia. Now, prolactin hormone is synthesized and secreted from the lactotrophs of the anterior pituitary gland. The secretion rate of prolactin is about 200 to 536 microgram per day per meter square, and half-life is 25 to 50 minutes. Now, prolactin is metabolized by liver 75% and the kidney 25%. The basal levels of prolactin in women averages 13 milligrams per ml, and in men it averages around 5 nanogram per ml. Initially, it was found to be secreted in a pulsatile manner from the lactotrophs of anterior pituitary. But these days, prolactin has also been isolated in hypothalamus, placenta, mammary glands, and even in the inner lining of the uterus, that is endometrium. Now, there are a few drugs which cause hyperprolactinemia. So, iatrogenic cause is the first one we should be looking at, and hyperprolactinemia accounts for 20% causes of amenorrhea. And what happens is, because of this hyperprolactinemia, there is an inhibition of GnRH released from hypothalamus, and these drugs which cause hyperprolactinemia may make the patient amenorrheic. Now, there is a chance that amenorrhea can be associated with hyperprolactinemia. And galactorrhea is the most frequent observed abnormality associated with hyperprolactinemia because of the hyperfunctioning of the lactotrophs. Now, hyperprolactinemia that is severe or associated with menstrual disturbances or galactorrhea should be confirmed by a second test of serum prolactin. And whenever you are dealing with a case of hyperprolactinemia, you should always measure serum TSH. Now, if there is a clinically significant hyperprolactinemia and it is not explained by the patient's hypothyroidism or drug use, we should do a CT and MRI scan of the sella turcica to rule out microadenomas or microadenomas. Now, there are some drugs which can cause hyperprolactinemia. The drug-induced hyperprolactinemia can be caused by tranquilizers, antidepressants, antihypertensives, narcotics, and even metoclopramide, which is used as a galactogogue, can also cause hyperprolactinemia. Now, mechanisms that produce increased prolactin, we should understand that normally there is a dopamine which suppresses the prolactin production. If there is a mass which compresses the stalk of the pituitary, the dopamine feedback pathway is interrupted and it can no longer inhibit the prolactin. So, this leads to increased prolactin levels. Also, GnRH will not be able to pass through and there will be decrease in luteinizing hormone and decrease in the follicle stimulating hormone. And if there is an increase in prolactin and there is a decrease in LH and FSH, there may be a decrease in the estradiol levels, and the patient has options of treatment by hormone replacement therapy to improve her hormonal profile. Now, hyperprolactinemia can also be caused by psychoactive drugs which suppress dopamine. So, even if the hyperprolactinemia has been caused by drugs which suppress dopamine, we will see that there is a decreased FSH and LH levels. And whenever there is a prolactin secreting adenoma producing excess prolactin, that can also lead to increased levels of prolactin. So, prolactins can be increased by three mechanisms. Number one is because if there are any stalk tumors, and the stalk tumors which is preventing the transmission of dopamine, any lactotrophs or pituitary adenomas, then any drugs which can cause hyperprolactinemia which suppress dopamine. So, any drug that suppresses dopamine can cause hyperprolactinemia. Now, there are two types of prolactin secreting adenomas, microadenomas and macroadenomas. Microadenomas are less than 10 millimeters. They are diagnosed on MRI, and macroadenomas are the ones which are more than 10 millimeters. Now, microadenomas are associated with visual symptoms and they must be treated with surgery. And microadenomas are benign and they usually can be treated with bromocriptine. Now, bromocriptine is a dopamine agonist and they can shrink the adenoma, and microadenomas need to be followed up clinically and macroadenomas need to be followed up clinically with MRI. For microadenomas, we can do an MRI yearly, but for macroadenomas, we need to do MRI every 3 monthly. Now, the upper limit of prolactin level in most laboratories is 15 to 20 nanogram per ml, And when the amount of serum prolactin exceeds this upper limit of 15 to 20 nanogram per ml, we call it as hyperprolactinemia. The common cause of hyperprolactinemia can be physiological, pathological, or drug-induced hyperprolactinemia. Now, patients with hyperprolactinemia may remain asymptomatic, or they can present with signs of symptoms of hypogonadism and galactorrhea. Physiological, pathological, or pharmacological conditions can cause hyperprolactinemia, and any condition that affects the secretion and clearance of prolactin can cause hyperprolactinemia. Physiological hyperprolactinemia is transient and adaptive, whereas pathological and pharmacological hyperprolactinemia are symptomatic with unwanted long-term consequences. The physiological causes of rise in prolactin levels include pregnancy, nipple stimulation and lactation, exercise, stress, hypoglycemia, myocardial infarction. Any surgery can cause rise in prolactin levels. Seizure, sleep, newborn period, sexual intercourse can rise prolactin levels. Meals. And to avoid unnecessary and costly imaging, mildly elevated prolactin levels, that is between 20 to 40 nanogram per ml, are best repeated and reconfirmed before the diagnosis of hyperprolactinemia is made. Coming to pregnancy and prolactin. During pregnancy, the pituitary gland increases in size, also increasing the size of lactotrophs. So, the pituitary gland doubles in size during pregnancy, and serum prolactin increases throughout the pregnancy, and it reaches a peak at the delivery. And the rise in prolactin during pregnancy is possible because of the increase in the serum estradiol concentrations. After delivery, estradiol secretion will decrease, and serum prolactin levels becomes normal, and the prolactin has got a function for milk synthesis and milk ejection. So, for that prolactin is high, and now the lady can breastfeed her babies. In pregnancy, serum prolactin usually becomes 10 times the normal with a range of 35 to 600 nanogram per ml at term, and prolactin in amniotic fluid is 100 times more compared to the level in the maternal and fetal blood. So, why there is so much of prolactin in amniotic fluid? The reason is still unknown. We only know that serum prolactin in pregnancy becomes 10 times the normal. It goes up to 35 to 600 nanogram per ml in a term gestation. Now, nipple stimulation increases prolactin secretion, which is mediated by neural pathways during breastfeeding. And prolactin secretion increases transiently with suckling reaching up to 300 nanogram per ml above baseline. The prolactin levels increase to 10 nanogram per ml above baseline in the first week of pregnancy and continue to rise for several months after delivery.